Hello, everybody. I would like to welcome you to the breakout session on giant cell arteritis, or GCA. I'm Beth Westbrook. I'm the Senior Director of Outreach at the Vasculitis Foundation, and I'm here today to introduce our exciting presenter and moderator for today's session. I wanted to start out by telling you we're really very fortunate. Not only did Dr. Maas sit on the core committee with the guidelines, he is also the lead author on the giant cell arteritis GCA guidelines. Please allow me to introduce our presenter. Dr. Mehrdad Maas is the Director of Allergy, Clinical Immunology, and Rheumatology at Kansas University in Kansas City, Kansas. A little bit about his background. Dr. Maas is a rheumatologist with special training and skill in diagnosing, treating, and preventing disorders related to inflammation of the joints, muscles, and ligaments. He is a professor, a division director, and a rheumatology fellowship program director in the Division of Allergy, Clinical Immunology, and Rheumatology in the Department of Medicine at the University of Kansas Medical Center. And now I would like to introduce today's moderator. Dr. Rennie Rhee is at the University of Pennsylvania Vasculitis Center, located in Philadelphia, Pennsylvania. Dr. Rhee specializes in the diagnosis and management of vasculitis. Her research program spans clinical and translational studies in humans that seek to understand the disease pathogenesis and disease heterogeneity of multiple types of autoimmune vasculitis. Currently, her research focuses on the role of the human microbiome in vasculitis and the identification of novel biomarkers in vasculitis. At this point, I would like to turn this session over to Dr. Maas. Thank you both for being here.
Those who are here joining us know about vasculitis in general and what it means, that it is an inflammation of blood vessels. But as you may know, we have different sized blood vessels in the body. We kind of categorize them into three major groups. Large vessels, which can extend to medium, which is the topic of discussion today in this particular presentation, giant cell arteritis, and then there's the other one as Takayasu's arteritis. Then we have medium vessel vasculitis, which include polyarthritis nodosa and Kawasaki's disease, discussed in a different group here. The smaller vessel diseases or ANCA-associated vasculitis, and then the other vasculitis that are not really the topic of discussion here or the scope of this current effort by American College of Rheumatology and Vasculitis Foundation. So we'll basically talking about the large vessel vasculitis. So some initial historical account of how this came about. It's always good to know how the diseases were recognized and what happened as main kind of presentations and also recognition of the disease, and then treatment and management options that were developed later on. So one of the first, probably the first publication in the literature about what could have been giant cell arteritis came about in 1890 in London by Jonathan Hutchinson. But this was better described both systemically and symptomatically, as well as the recognition of what can be seen in the temporal artery biopsies by Dr. Baird Horton in 1932 at Mayo Clinic. And it wasn't until 1950 when steroids or cortisone at that time was not only developed, but also started to be used kind of globally when Drs. Kendall and Hench kind of developed this at Mayo Clinic before 1950, but won the Nobel Prize for this development. And this really changed the whole kind of spectrum of disease management of any kind of inflammatory condition, not just giant cell arteritis and polymyalgia rheumatica, for instance, but those of rheumatoid arthritis and other diseases. So that was a major development. But letting you know that even to date, the prednisone has not been FDA approved for this indication or many other indications, although we definitely recognize and everyone knows how effective they are in the management of these diseases. So back in 2012, the experts in vasculitis got together at Chapel Hill and developed a nomenclature or definition of different vasculitides. And in that effort, they described large vessel vasculitis as those that affect the large artery more than other arteries. It could also affect medium-sized arteries, but mainly the arteries or blood vessels that take the blood from heart, from here, taking the blood from heart to other organs, and especially the aorta, so ascending and descending aorta. Oh, look too fast. So, and also its major branches, such as subclavian artery, the carotid and vertebral arteries, and going down in the abdomen. The GCA, or giant cell arteritis, by itself was defined as arthritis or inflammation of the arteries with some manifestations or pathologic findings that we could see under microscope of the arteries, which would include granulomatous changes of these major arteries, including the temporal arteries, of course, which coming from the carotid branches, such as the superficial temporal artery, which goes to the temporal region of the head. Now, some of the manifestations are not always available on the pathologic kind of specimens, but that is more of a detailed information about this. So what happens if you cut the artery and look at it in cross-sectional view like this, you would see different layers of the artery, the kind of inflammatory cells that kind of invade the artery. But more importantly, in the case of giant cell arteritis, what happens is that you have these, what we call hyperplasia, the fibrosis or scarring and enlargement that occurs in the lumen. So this used to be where the blood was flowing through this artery, like a tube, but now it's all filled, so the blood cannot pass through. So this becomes a stenotic or very narrowed. And then when blood doesn't flow to an organ, obviously oxygen and nutrition doesn't get to that particular organ. In this case, for instance, the eye. And so ischemia occurs, meaning that there's a lack of all these nutritional and oxygen and such to that organ. And then in case of eye, patients can develop vision loss. Generally, this disease occurs, as you may know, in those who are over age of 50, but really the highest incidence of particularly of giant cell arteritis is generally around age 70 or older. It is seen more in female population than male, with a kind of a ratio of 3:1, and more in Caucasians than other ethnic backgrounds. I don't want to go through the details of some of these, but how this were developed, as Dr. Chang already discussed it, but in particular for this purpose of this presentation, let me define what we talk about when we say talk about steroids, or what we really call it these days as glucocorticoids. But to be kind of simple and kind of shortened, I'll call it steroids. When we talk about IV steroids or pulse intravenous glucocorticoids, we're talking about kind of administering steroids through infusions through the vein in a liquid format. And usual treatment is with methylprednisolone, a form of steroid. And generally 500 milligram to 1,000 milligram is given, usually for 3 to 5 days. When we talk about the steroids in the form of oral prednisone, we're talking about prednisone at a high dose of 1 milligram per kilogram, usually up to about 60 milligram in general, but some, including some ophthalmologists, tend to give higher dose of 80 milligram daily. Within the discussion that we're going to have, you may hear moderate dose oral glucocorticoids. By that, we mean basically half of that dose, or about somewhere between 10 to 40 milligram of prednisone in adults on a daily basis. And when we talk about low dose glucocorticoids, we're talking about a smaller amount, anything equivalent or less than 10 milligram of prednisone daily. The other things we talk about are non-glucocorticoid immunosuppressive or steroid-sparing agents, and these are some of the ones that we were talking about. And biologics, we mainly talk about tocilizumab here, and then surgical intervention, which could be anything such as angioplasty or putting stents, opening up the blood vessels, or vascular bypass, meaning that we go and connect the vessels to bypass where it's narrowed and there's no blood flow. So let me start with a case of a patient that I will go through this presentation. As this patient presents to us a different stage of her disease, and using that, we will discuss how we would manage this patient based on the recommendations by ACR and VF, and how we would kind of go through these steps gradually together. So this is a case of a patient, 71-year-old Caucasian lady, who went to her primary care physician because over 6 weeks ago, she had developed this muscle ache about around the shoulders and hips, really bad pain with stiffness, fatigue, even fevers. We usually call this kind of myalgia. You may hear that term along with this stiffness and fatigue. And then subsequently, she developed headaches over her temples. And this was new for her. She generally didn't have this kind of headaches. She also noticed that over the temples, there were these, what she described as ropey veins, kind of enlarged kind of vessels. So the primary care physician was concerned and started her on prednisone 30 milligram daily and referred her to Rheumatology clinic. So this is the patient, actually a patient of mine that I had seen previously, years ago actually. So presenting with headaches, but this kind of enlargement of the temporal artery, somewhat nodular. But when you touch that, the pulse of the artery is diminished. And then this is kind of tender, around the scalp is tender to touch. Even combing the hair could be painful. When we examined the patient, other than that, and then we went through laboratory studies, we noticed that patient had developed anemia, as well as elevation in inflammation markers, ESR or sedimentation rate, as well as C-reactive protein or CRP. So the rheumatologist, the staff rheumatologist was seeing the patient with a fellow in the clinic, and the fellow remembered that she had heard about Europeans using temporal artery ultrasound for diagnosis of giant cell arteritis because they had a high suspicion that this patient had GCA, and suggested that we proceed with ultrasound, and then, if negative, maybe consider bilateral temporal artery biopsies, but that wasn't available right away. So to confirm the diagnosis, how should we proceed? Should we go ahead and get a temporal artery ultrasound, or should we go ahead and get a temporal artery biopsy? As Dr. Chang discussed, these guidelines, different guidelines that we have, are meant for United States and Northern America. And what we have here is a recommendation of proceeding with temporal artery biopsy rather than a temporal artery ultrasound. And why is that? Currently, the experience with ultrasound and expertise with ultrasound, both for physicians, rheumatologists, and the technicians who perform this, is limited. Now, there are some centers in the United States that are doing this and doing it very well and successfully, but this is not widespread in the United States, and it's not available. And so until that happens, until we kind of are able to get the temporary ultrasound quickly and expertly, as do Europeans do, then until then we were recommending to proceed with the temporary biopsy. Now, temporary ultrasound is not kind of easy to do. It's very operator dependent, and hence the need for expertise of the sonographer, but also the physician who's managing this patient, or the radiologist who's, for instance, reading this. And it can be affected, like anything else, by the presentation of the patient and steroid treatment that could make the findings kind of go away, disappear if it's not done soon. So what about other modalities? Could we proceed with other imaging studies to diagnose temporal arteritis or temporary or giant cell arteritis without performing temporary biopsy? Well, again, our recommendation is to proceed with temporary biopsy instead of other modalities such as MRI or magnetic resonance imaging with contrast. And that is partly because although these studies have shown that MRI and even CTA and such can help a CT of CAT scan of the cranial vessels can help with diagnosis, they're still not gold standard. They have not still become widespread, not just in US, but elsewhere in European countries. And as you know, the MRIs and the technique and the expertise for this particular protocol is not really available all over the country. In certain institutions, there is availability and expertise. For instance, we do it here, but again, it's not gold standard compared to, for instance, ultrasound that has been shown to be kind of very helpful in diagnosing GCA in European countries. So how soon should we biopsy the patients? Because, you know, patients develop these and then they're put on prednisone or steroids, and what is going to effectively change the pathologic findings on the biopsy. So the recommendation again is to go ahead with temporary biopsy, but to try to get the biopsy within 2 weeks of starting steroids. Now, it does not mean that you can't do it later, but the sooner the biopsy is done, the sooner the pathology is reviewed by the pathologist while on steroids, the better quality of the pathology you will have, and a better diagnosis or more kind of established diagnosis. Because pathologic changes, things that I said that could happen in that temporary biopsy slide that I showed you, can disappear or change and not be so characteristic or diagnostic and cause a dilemma. So the sooner you do the biopsy within 2 weeks, the better it would be. Now, there are cases where patients have been on prednisone longer than 2 weeks, and the biopsy is still abnormal. There are studies that have been published and show that, but we're talking about in general terms. So the pathologist, once you do the biopsy one-sided, the pathologist kind of says that, well, the biopsy is negative, but the biopsy was only 0.4 centimeter long, so very small, tiny biopsy. So is this temporary biopsy at this length sufficient to exclude the diagnosis, to say that the patient doesn't have GCA? Well, the recommendations are that we prefer to see that that segment of the temporary that is kind of resected and reviewed under pathological, but by the pathologist, is over 1 centimeter long, so that you could have a better chance of recognizing the pattern of disease and pathology that you can see under the on the slide. Partly because the GCA is known or thought to be focal and segmental, meaning that if you take a small specimen, you may miss some of those abnormalities and inflammation or giant cells that you may typically see, because maybe you didn't take a large specimen to see the other part of the biopsy or the artery that had those abnormalities. So it will reduce your diagnostic yield if the biopsy specimen is too small. And hence, the voting panel, the experts recommended a longer biopsy, and in part because really taking a smaller biopsy versus a little bit longer biopsy doesn't increase the risk of this procedure by much. So how about proceeding with one-sided biopsy or biopsying both temporal arteries on each side of the temple? Recommendation is that we should proceed with one side. And which side is that? Typically the side that patient is symptomatic on, as headaches on that side, and scalp tenderness, or temporal artery has obvious abnormalities on exam or on by just visualizing it. Now, biopsying of the other side can also be considered, which we call bilateral then, when this the symptomatic manifestations or exam are not localizing to one side. For instance, patient doesn't have a specific tenderness or abnormality on one side, or once you've done the first side of the biopsy, like the right side, and it's negative, but you still have high suspicion that this is a kind of cranial GCA involving the temporal arteries, then you can proceed with the contralateral or the other side biopsy. So in this case, the patient had the first biopsy that was small and was negative. So you proceeded with the contralateral side, going to the other side of the temple to get the biopsy. And then the pathologist lets you know that the physician that the temporal artery this time was 3 centimeters long, and it was positive. Positive meaning that the pathology showed all the nice characteristic findings of cells, some giant cells that is hard to depict here, kind of disruption of the elastic lamina, but more importantly, you can see that the lumen of the artery is basically blocked. It's kind of filled with these fibrotic tissue. So now the diagnosis is confirmed. Now that we've confirmed the diagnosis, are we done? Do we need to do anything else to investigate, for instance, if this inflammation of the large vessel is anywhere else in the body? Not just in the cranium and head and temporal arteries, but could it be anywhere else? And is that important? So the recommendations are that we proceed with non-invasive vascular imaging after this diagnosis or recently diagnosed giant cell arteries patient to evaluate for involvement of the large vessels elsewhere in the body. And what are the tools that we have for this? There are different imaging studies. More often we use MRI and CT angiogram, not the old-fashioned angiograms, but these techniques that are easily better available. But we tend to image the neck, chest, abdomen, and pelvis for involvement of these large vessels, where we typically see these abnormalities. And once we do these imaging studies, it will give us a clue. Now, we're not doing this at this juncture for this particular patient for the purpose of diagnosis, but we're doing it to see if there's any other vessel involvement elsewhere that could give us indications of, for instance, large vessel involvement of the aorta, aneurysm, or kind of enlargement of the diameter of the aorta that could be concerning, or narrowing stenosis of the vessels in different parts, these different large vessels that could have implications for future management and monitoring. So the fellow was telling the staff physician that, she recalled the patient that had symptoms and such, and they did bilateral temporal biopsies, but the biopsies were negative. Yet the symptoms and the presentation was so convincing that the patient was started on prednisone 60 milligrams daily. So are we done again in this case? Do we need to do anything else for this patient? Especially if the temporal artery biopsies are negative. How else can we make the diagnosis? Well, the recommendations are that if you have negative temporary biopsy, then non-invasive vascular imaging of large vessels, namely the things that we talked about, MRA or CTA, are helpful in establishing and confirming the diagnosis. In general, vasculitides are diagnosed not just by presentation and clinical manifestations and labs and such, but really the diagnosis are confirmed by pathology if there is a specimen that could be kind of obtained, for instance, temporary biopsies in here, or by imaging studies that will show enlargement or narrowing or specific features of a particular vasculitis that would be characteristic of that particular vasculitis condition. So in this case, we could look for extracranial or what is described as large vessel vasculitis in giant cell arteritis by looking at these other vessels in the body. There is also another modality used, PET scan, that you may have heard about, but again, ultrasound is also useful in this setting, again, by an expert sonographer and physician. So now, the patient, to summarize, is a 71-year-old lady, biopsy-proven giant cell arteritis. And now that the discussion is with the patient and the fellow and the staff, what to do next? How do we treat this patient? So there are different aspects of management of patients with giant cell arteritis, and it really depends on their manifestation, presentation, and what else you find in the course of this diagnosis and what kind of complications they may have. So if a patient presents without cranial ischemia, and by that we mean transient vision loss or double vision or even permanent vision loss. So there is none of that ischemic, severe ischemic event, including sometimes this can lead to stroke, then the recommendation is that high-dose oral glucocorticoids. Remember what we talked about, those in the range of 1 milligram per kilogram or generally about 60 milligrams of prednisone daily is recommended over using IV forms of steroids, which is a higher dose of steroids. Now, it has been shown in some studies that IV steroids can improve or improve the disease or reduce the number of flares and help with the remission of the disease. But at the same time, it may increase some of the side effects and risks. And in cases where there is no cranial ischemia or critical ischemia elsewhere, then you may not need IV methylprednisone. So patients with newly diagnosed GCA, should we use high-dose oral glucocorticoids, prednisone 60 milligram, or should we use lower dose, such as 30 milligram or 40 milligram prednisone? Some studies and some of these studies that have been done actually have compared these patients on a lower dose of prednisone, and it can be done. But when do we do that? When do we use a lower dose of prednisone is when there are some other concerns, severe diabetes or some other concerns about high dose prednisone, especially if the patients don't have these ischemic manifestations or vision loss or any life or organ threatening complications. We could use it, but in general, 60 milligram of prednisone or 1 milligram per kilogram is a starting dose, and this will be tapered gradually within weeks to months, and we can talk about that more. So how should we treat with prednisone? Should we use prednisone or steroids on a daily basis, or should we use it every other day? Some do use kind of every other day dosing to reduce the potential side effects of steroids. But it has been shown that when you use the prednisone or steroids on a daily basis, you have a better chance of improving the disease, better chance of having remission and reducing those flares and such in patients rather than every other dosing. So the recommendation is to use everyday dosing. So then if a patient is diagnosed with GCA currently and we start the steroids, do we start the steroids by themselves, which has been the traditional way of managing GCA? meaning prednisone, 60 milligram, and gradually tapering within a year, 2 to 3 years? Or do we add a steroid-sparing agent, in this case, tocilizumab, rather than just steroids alone? And we'll talk about this, but the tocilizumab was indeed the only FDA-approved treatment for GCA after a publication of this main study in 2017. And so experience has shown that it's very effective as a steroid-sparing agent, and it is recommended that it could, if possible, it could be used as an initial treatment along with steroids. But other medications, and in particular methotrexate, has been studied more than anything else that can be used as steroid-sparing agent to manage the patients with GCA, so that to be able to taper the prednisone more rapidly. However, some patients may just choose and opt, as well as the physicians, to have steroids alone, and that could depend on many factors, patient values and preferences, as well as the physician's experience, but also other factors, infections and side effects and such. We have to also remember, as Dr. Chang was reporting, that tocilizumab is not, or these biologic agents in general, are not available everywhere, and they can be costly, so that may limit its use. Now, we're hopeful that having a guideline that states that these drugs are indeed helpful in managing patients will kind of influence, or at least help the insurance companies and others to consider approving these drugs for use. So this is the article that I said. It was really pivotal manuscript that stated that tocilizumab is indeed helpful in management of patients with GCA. So you may hear about this quite a bit. Just briefly, in the interest of time, I'm just going to say that tocilizumab is a biologic therapy. Why is it used? Because we know that interleukin-6, which is a molecule in the body that works in a pathway of inflammation, it has been shown that it is elevated in patients with GCA and plays a role in development of the inflammation in patients with giant cell arteritis. And that tocilizumab, which is a antagonist, which blocks that IL-6 receptor, blocks the effect or the action of the IL-6 in that pathway of inflammation, reducing that, so improving the disease process by itself, just like the prednisone does in a different manner. So this study had about 251 patients. It was a randomized controlled trial. What they did, they used tocilizumab subcutaneous injection, 162 milligrams for weekly or every other week, with prednisone taper within 2 and 6 weeks, which is a fairly rapid taper of prednisone for patients with giant cell arteritis. And they compared this to placebo, meaning patients who didn't have tocilizumab but had something similar to it, which was placebo and like a sugar tablet and such, with the prednisone, either tapering within 26 or 52 weeks, and showed that indeed those who received the tocilizumab, somewhere between 53 to 56% of them were able to remain off of steroids at 52 weeks of follow-up, versus only about 14 to 18% of patients who only had prednisone and not the actual drug. And it showed that by doing so, you would reduce the total amount of steroids that you would be exposing the patient to. And the side effects were really not that kind of prominent here compared to the placebo. So this patient comes back to you right after the biopsy or the first day or two, and tells you that she's developed this kind of vision changes, either diplopia, meaning double vision, or transient loss of vision, temporarily a curtain coming down and not being able to see one eye for a few seconds even. This is called ACRVF. So what would you do in a case like this? Patient now has developed ischemia, and it's important. We call it cranial ischemia, and may have an impending vision loss. due to lack of good perfusion of the blood to the eye. So with this, we call this threatened vision loss. And in patients who have been recently diagnosed with GCA, we recommend starting IV pulse glucocorticoids, IV steroids, what I described initially as methylprednisolone, high dose, usually 1,000 milligrams or 1 gram, daily for 3 days. Although there are some conflicting results about how effective this could be, but this is the best we have that we can offer immediately to prevent the vision loss or save the other eye from having this kind of manifestation or potentially vision loss. So when patients have these highest risk of this, we could consider it, but then again, we have to discuss this with the patient and the physician together and see if it's appropriate to manage the patient that way. So 9 months into the treatment, patient's now on 9 milligrams of prednisone, and she comes and says, oh my God, I'm hurting in my arms, my legs. When I move my arms, do activities, lift them, bring something down, my arms get tired easily and hurt. And when we examine the patient, we notice that the blood pressures are not equal. One side is higher than the other. And then when we listen with the stethoscope, we notice some bruit, meaning the sound of blood flowing through the narrowed or atypical artery blood vessel. And in particular, looking and listening around the side of the subclavian over the chest, and we image the patient, and this is what we see. This is the aorta, the big artery coming out of the heart. These are the branches, subclavian artery going to right, which eventually goes to axillary and brachial artery, which goes to the arm. Same thing here on the left. And these are carotid and vertebral arteries going through the neck to the brain up here. And what you see here, the artery is fine here, but it gets narrowed as it goes distally. Same thing here, and it gets narrowed. And this is where you hear the bruising sound and then kind of narrowed artery that leads to lack of good perfusion of the blood and causing those what we call claudication, tiring of the arms and such. So if the patient presents with this large vessel involvement, this is what we mean by large vessel involvement or progression of disease in that manner, what should we do? So patients with these, what we call extracranial large vessel involvement, the recommendation is that not only we treat with glucocorticoids or steroids, but also add an agent if we haven't already, meaning medications such as tocilizumab, and if not possible, methotrexate. So let's talk about surgical intervention in these patients. Sometimes the damage or the narrowing of the blood vessels is so extensive that patients develop those manifestations, the narrowing that I told you about. But in patients with severe GCA who are developing worsening signs of these ischemia or claudication or any other manifestation, aortic dilatation and such, who are on immunosuppressive drug like prednisone, say 10 milligrams of prednisone, if we notice this, we tend to increase or escalate the immunosuppression rather than jumping into having a surgical intervention. So better to intensify the treatment than going for surgery if possible, partly because when some of these narrowing of the blood vessels develop, the body kind of responds to that by developing what we call collateral blood vessels. So it can produce additional blood vessels in time, not right away, it takes time for that. And then kind of allow the organ, the body part to still get blood and nutrition and oxygen. And so that you avoid, your body avoids developing this ischemia that could be devastating, right? We can consider immediate surgical intervention, however, if there are other manifestations. For instance, the aorta is so enlarged that it's at risk of rupture, and that is a dangerous, life-threatening condition. And in those cases, of course, we have to consider surgery. So with those patients with GCA who are undergoing vascular surgical intervention, some kind of vascular surgery or intervention for the purpose of complications of the GCA, the recommendation is to use high-dose steroids, glucocorticoids, perioptically to allow to kind of suppress that inflammation if the patient has active disease. And you can decide on that disease activity based on many things, exam history, laboratory findings, and such. The data is limited, but that is basically the recommendation, and partly the recommendation comes from the experience with patients with Takayasu arteritis in similar situations which require surgical intervention. So what about those inflammation markers, ESR or CRP? How do we address those? How do we monitor patients with those? Well, this patient comes back in about 14 months later after being on therapy, and her SID rate is now 38, a little bit higher than before. CRP is a little bit elevated at 11 milligram per liter. So this is kind of different now compared to what it was before. However, the patient denies any symptoms, either of the head, cranium, or the extracranial symptoms like claudication and such. And you examine the patient, everything looks fine and such. What should you do in those cases? Should you intensify the treatment? The patient is on, I don't know, 3 milligrams of prednisone, and now you want to increase it up to 40 again? Or should you wait and see if there's anything else that's going to help you make a decision about adjustment in therapy? Recommendation is that just increase in the levels of inflammation markers alone without any other manifestation. That does not necessarily mean that you have to adjust the dose of therapy or intensify the therapy. And instead, clinical observation and monitoring more frequently, more closely, and even if needed, imaging studies like MRA that we talked about may be helpful. But we don't just increase the dose of prednisone for minor elevation in inflammatory markers without associated symptoms or clinical signs. So 2 months later, patient comes in. You're seeing this patient more frequently because you notice that the inflammatory markers are rising. And now she tells you that, oh, I have symptoms, I'm muscle aching, fatigue, I'm stiff in the morning when I get up. Although the exam is really unchanged, the inflammation markers, ESR and CRP, are risen even further. So what should you do for this patient? So this is basically a relapse of disease or flare of the disease. And patients who are on moderate to high dose of steroids, right? So we're talking about somewhere between 10 to 40 milligram or even higher of steroids. And they come in with relapse, with flare of the disease. If they're not already on a different drug, steroid sparing agent, recommendation is to start that medication. Could be tocilizumab, could be methotrexate and such. So any relapse, if you don't do anything about it and leave the medication the same, it's unlikely to improve by just tapering the prednisone alone. You need to do something now in this case. Now, if the disease relapse occurs with cranial ischemia, with more concerning manifestation of the disease, then adding a non-glucocorticoid immunosuppressive agent and increasing the dose of glucocorticoids is, again, more important than just steroids alone. Again, in this case, tocilizumab, methotrexate. Now, if they present with polymyalgic symptoms like myalgia, muscle aches, pain, stiffness, and really not a whole lot of other things, sometimes those symptoms, especially when patients are on lower dose of prednisone below 10 milligram and don't have these other manifestations, ischemic manifestations, then just adjusting the dose of prednisone a little bit may suffice. So if they have relapse of the disease while receiving high doses of steroids or moderate doses of steroids, Then again, oh, I think I went through this again, right? Why did it go back? All right, sorry about that. So if they have a relapse of the disease with cranial symptoms while receiving steroids, the next step is to add steroid-sparing agent, tocilizumab or methotrexate over tocilizumab with steroids over adding methotrexate to steroids. So again, first-line therapy here would be tocilizumab, which is usually done in a subcutaneous format, self-injection. Patients do it themselves. Some of you may already have that, but there's been some data to suggest that IV tocilizumab works just fine in such cases patients who require tocilizumab. Now we know that the methotrexate effect is not as good as that of tocilizumab, but in some cases we just can't do tocilizumab, and therefore we use methotrexate in those cases. Just a couple of kind of minor or as far as management of the patients, which may not come to play, but there has been some discussion about whether or not using statins, those medications that control the lipids, the cholesterol in the body, may help with management of patients with GCA. The data, the literature does not support that. So our recommendation is against using statin for the purpose of treating GCA, not for the purpose of managing cardiovascular manifestations of patients or patients who have risk factors, for instance, those who have high cholesterol or have had a history of coronary artery disease, heart attack, that sort of thing. That is not the case, but for the purpose of managing GCA, statins do not play a major role. Also, there's been data about using or taking aspirin as part of management of patients with giant cell arteries. The more research and data that was presented points to the fact that if there is critical or flow limiting, meaning blood doesn't flow nicely through the vertebral carotid arteries, which also could then affect the eyes, but not only that, the vessels that go to the brain, and some patients that may develop strokes and such. In those cases, adding aspirin is going to be helpful because it has this antiplatelet activity, and it could prevent some of these ischemic events. But efficacy of aspirin in patients who do not have these manifestations, severe manifestations, is really not known. Again, that's aside from those patients who already have other cardiovascular risk factors, heart disease and so forth, that require taking aspirin. That they continue with that, but not just for the purpose of managing GCA. So then what do we do with these patients? So somebody who has been on steroids or off of steroids, what do we do later? How do we follow them? Well, patients, this particular patient returns now 2.5 years after her initial diagnosis, hasn't had any relapse or recurrence of the symptoms, off of treatment. Labs are good, no inflammation, and exam is unrevealing. What should we do? How do we monitor the patient? Should we, as rheumatologists, follow the patient, or just let the primary care physician send them back to you when there is a concern? This is the only strongly recommended recommendation from the panel to suggest that the patients with giant cell arteritis indeed need long-term clinical monitoring over no clinical monitoring at all. And that is because of the development of complications of the disease later in life, those aortic dilatation that we talked about, or stenosis, but more concerning about the aorta, and then persistence of inflammation that could occur very smoldering, not knowingly, and if not being managed and monitored throughout the years. So what do you mean by monitoring? We mean examining the patient, asking history and such, getting labs, monitoring markers. And this is, as I said, the only strong recommendation to prevent the potential risk of catastrophic outcome in these patients. But unfortunately, we don't know the optimal duration of the therapy. We don't know how long we should really monitor the patient for, and for how many years, for instance. The consensus is that these patients require monitoring. Now, it doesn't mean that you have to be seen every month or two, but maybe every 6 months, every 12 months. But in general, also, the other recommendation, or this is called ungraded position statement, is that we really don't know how long we should also treat the patients with prednisone or steroids. The goal is, however, to minimize the use of steroids to kind of reduce its potential side effects. But sometimes some patients require tiny bit of prednisone, 3 to 5 milligram prednisone, to keep their disease under control. Kind of depiction of what we talked about. And since I already talked to you about it, this is the management of patients with and without ischemia. And here I'm going to tell you about what we talked about already, that most of these kind of recommendations are conditional. In the United States, we proceed with ultrasound, with temporary biopsy rather than ultrasound for now, but that will change likely. Kind of usefulness of the imaging studies for large vessels, high dose steroids as the initial therapy, daily steroids used rather than every other day, IV steroids for threatening vision loss, tocilizumab as a steroid sparing agent to sustain remission. Methotrexate can also be considered, and addition of these drugs when patients have severe large vessel disease, and importance of chronic monitoring.